Well, the weather outside is frightful, and today we're talking about cold emergencies. Wouldn't that have been good if we did this in December?
Yeah. What? It's still cold out here.
Yeah, but you can't really say the weather outside is frightful. Actually, that song doesn't have anything to do with Christmas time.
That's true. Isn't that the rapey one?
No, that's the I really can't stay.
Oh, yeah,
honey,
yeah.
take your pants off right now.
No, that's yeah.
I don't want to. You got to take your pants off right now. That song.
Okay. All right, just checking.
Anyway.
All right. Well, anyway, welcome to the Back to Basics podcast, hosted by Guardian Test Prep. We are talking about cold emergencies today. And actually, when I first read the title, I got really frustrated as an ER physician. And I'm like, how many times do people have to understand that a cold is not an emergency? But then I realized that we were talking about temperature. And
Are you serious?
Yeah, I did. I was like, that doesn't make any sense.
Stop
I'm not going to talk
coming to the
about
ER.
how people's colds, they're not an emergency. Yeah. So anyway, that's not what we're talking about. We're talking about cold emergencies, meaning like hypothermia.
Yeah.
Yeah.
Low temperature.
Low temperature. We do have a sponsor today. So our sponsor today is CPR Enroll. So if you are a AHA, American Red Cross, American Safety and Health Institute instructor, and you put on classes and things like that, CPR Enroll is an extremely robust, inexpensive class management system. Helps you get your people signed up, helps you schedule your classes, manage paperwork, manage your client list, send out emails, receive payment. I mean, just everything you could need to do to manage your classes. So check that out at cprenroll.com. We appreciate them sponsoring this podcast today. But
If you want a CE for this podcast,
oh yes,
go ahead and check out www.guardiancme.com and you'll get a free CE for watching this podcast and taking a short quiz.
Yep.
If you want more CEs, if you want to watch other podcasts or other educational videos and get CEs, if you're Amanda and you want to take 40 CEs in the first week of the program launching and costing me a decent amount of money, you can do that. Thanks, Amanda.
No,
I'm just kidding. No, we're happy for you to take care of all of your CEs through us. Check out www.guardiancme.com, completely free. You get a CAPC credit. It'll work with any state. You can submit that to your state and relicense.
Yeah. Awesome.
So you might as well, if you're listening to us anyway, get a free CE out of it.
I agree. And tell your friends. So, all right, cool. Amanda.
Share the load, Amanda.
All right. Well, again, today we're going to talk about cold emergencies. So when we think about cold emergencies, the first thing we're going to talk about
Snow.
is not snow. We're going to talk about hypothermia. So I want to talk about hypothermia. I want to talk about what hypothermia is. There's actually different levels of hypothermia, which I didn't actually know for a while. How do we treat hypothermia? And then I also want to talk about frostbite and frostnip.
We're not supposed to tell you. Told me I can't talk about nips.
That is a different context.
Okay.
But anyway, we're talking about frostbite and frostnip. So actually it is winter here in Michigan. I don't know where you're listening to this podcast. I know some people.
Or when. It could be 20 years in the future when the
20 years in the future.
The oceans have dried up.
And they'll be like, what is this cold emergency?
Yeah, what is
Global
it?
warming
What is
has
cold?
changed. Like, yeah, there's generations of people listening to this podcast in the future.
Oh, the before 4 times. Something like that.
That's true. Okay, fair enough. Do I have to talk about cold?
I'm in a mood today, clearly. I'll just let you.
Okay.
Go ahead.
Okay,
Hypothermia, frostnip, frostbite.
Now I'm thinking I have to describe what cold is so that people who live in this post-apocalyptic global warming, if they're listening to this podcast. Okay. Anyway, so we live in Michigan. It is cold here. It is snowing. And we actually do see hypothermia and the associated problems of hypothermia quite a bit in our emergency departments. You do it in the field and stuff like that. So it's important to talk about. But the first thing I want to talk about is basically like, what is hypothermia?
Being cold.
Not just being cold. So when we talk about hypothermia, what we're really focusing in on is our core body temperature, right? So our core body temperature, I mean, like we self-regulate, we keep ourselves at a certain temperature so our organs can function in the right way, so the blood flows correctly, all that good stuff. And we shunt blood here and there as we warm up and make older. Hypothermia is basically when your core body temperature drops below a certain number.
Mm-hmm.
Do you know what that number is?
90.
5.
You wouldn't let me finish.
Oh, sorry.
5.
So anything below 95 degrees Fahrenheit, which is
core body though. So if you
yes.
get a reading somewhere else, it could be different.
True.
Like if you're getting a tympanic reading, it's not your core body temperature.
No.
The best is rectal.
Best is rectal. And really the only way we can get a true core body temperature is like oral or rectal.
Gotta get up there.
So I'm just going to do this one by myself. Could we just turn his mic off? So anyway, so hypothermia is defined as core body temperature less than 95 degrees Fahrenheit or less than 35 degrees Celsius.
Oh, I was just going to be like, and what is that Celsius? Not thinking you had it in the notes.
Oh, yeah, I have it in the notes.
It would've been
I didn't
good.
do that math in my head. I have it in the
Would've been
notes
good.
right here.
Yeah. Celsius, for those of you who don't know, is a weird unit of measurement that other countries use.
True. It's a very American thing to say. So anyway, so there's different levels of hypothermia and different things happen at different levels of hypothermia, which I think is important to talk about. So really what we have is, and as we talk about these different levels, I think we should talk about, well, actually, before we talk about the different levels, let's talk about kind of the pathophysiology of what's happening within our bodies when we're suffering from hypothermia.
So our body kicks on some compensatory mechanisms in order to try
Right.
to warm itself back up.
Correct.
Right? So the first thing that would happen would be you'd have an increased metabolism.
Right.
So if we can speed up, remember, metabolism is how the cell itself is working, how fast and effectively it's working. If the cell can speed up, you'll raise your core temperature.
Right.
Just like if you're, that's why sometimes you have a fever when you're fighting an infection, your metabolism is increased because you're actively fighting an infection.
Yeah.
That can raise your temperature. Also, though, don't forget that the reason you get a fever a lot of times is because you have cells that are activating the temperature to go up through increased metabolism in order to try to burn that disease out. And create an environment that it can't survive in. So it's a little different.
But same concept, right? We're changed. The core body temperature is changing, which is why a lot of people say we shouldn't treat fevers because it's like it is your body's compensatory mechanism to fight off infection. But in this case, we're talking about temperatures, that fall below not core body temperature. This is not like it's less than 95 degrees outside.
Right.
That would actually be a very hot day.
Yeah.
So we're talking about core body temperature. So when the core body temperature falls below 35 degrees Celsius or 95 degrees Fahrenheit, again, our metabolism increases essentially to create energy, which energy is when you create energy, you create heat, right? Every
exothermic response.
Exactly. So we're going to create heat to try to warm ourselves back up. The other thing our body's going to do is it's going to shunt blood from our periphery to our core.
So by vasoconstriction. So if you've ever seen Batman Begins, when he's fighting Ra's al Ghul on the ice.
Where is this going?
No, go ahead. Just give me a second. You've ever seen Batman Begins? He's fighting Ra's al Ghul. He's training. Fighting Ra's al Ghul, who's the guy who plays Qui-Gon Jinn. It's what's his name? I'm getting Liam Neeson. Thank you, Jamie. Thank you, Jamie, the filmmaker.
Liam Neeson.
So Liam Neeson, he's like Christian Bale's fighting Liam Neeson. It's Ra's al Ghul. They're training, and he's all like, "I got you," and he's like, "You idiot! You sacrificed your footing for a killing blow because you never understand your environment." Later, Batman does understand his environment. Wait till the end of the movie. I won't spoil it for you. He hits with his sword on the ground. Christian Bale goes into the cold water, and then it quickly cuts to they're trying to warm up by the fire. Christian Bale, Batman, Bruce Wayne, is rubbing his arms. And Qui-Gon Jinn, no, sorry, not Qui-Gon Jinn, Ra's al Ghul. Wouldn't that be cool? Ra's al Ghul says, don't worry about your arms. Your arms will take care of themselves. Rub your chest. Right. Because he recognizes the importance of raising your core body temperature by shunting blood to the core. He knows that those arms are going to have vasoconstriction, push blood to the core. If we can warm the core up, everything else is going to work.
Right. Exactly. Yeah.
Hey, remember earlier when you thought that was a bad example?
Yes. I apologize. I apologize for everything that happened before this moment. So, right. We're going to purposely shunt blood from the periphery to the core. And we're going to increase metabolism.
Yep. So muscle tone will increase.
Muscle tone will begin to increase. So this is as we continue to get colder, right? So what happens if that doesn't work, right? So now the next step in that process of the pathophysiology of hypothermia is then we're going to start to see, again, our muscle tone increasing. And then what else are we going to see start to begin?
Shivering,
right? And again, it's our body's way of creating motion, which creates heat.
It's such a good vibration.
If you break out into song right now,
I'll do it. All
right. So as we get colder, as the core body temperature does not raise and we get colder. And again, this is the pathophysiology of hypothermia when like what our body does. Like our response to hypothermia. Our body typically, unless we're moved into a new environment, these mechanisms won't work. Does that make sense what I'm trying to say, I guess? Like I don't want you to think that like I'm telling you like, oh, and you're just going to keep getting colder. Like, why is the body trying if it never works? It works to a degree, but if you stay in that cold environment and that temperature, and you know what I mean, it's going to continue to go down.
You're scientifically explaining that if you stay in a cold environment, you'll get colder?
Well, I'm saying like we're talking about body's response and mechanisms.
So you're just saying like it will never. Okay, what you're saying is let's say muscle tone increases and we start to shiver. we're not just now going to permanently be able to exist at this environmental temperature.
Right.
Like, it
that's
will
what I'm
get
saying.
worse the longer.
Yeah. The outside temperature does not need for us to continue to colder, for us to start getting colder and these mechanisms not to work. Does that make sense?
Yeah, I just think
confusing?
it was unnecessary.
Okay. Fair. All right. I mean, anyway.
Anyway, what happens next after shivering?
Sure. Okay. So once we shiver and we start to continue to get colder from our core body temperature, we actually start to deplete our glucose and glycogen stores, which makes sense because we talked about an increase in metabolism, right?
It's energy. Yeah.
It's energy. What does the body use to make ATP and energy and thus heat? Glucose, right? Sugar. So we deplete our glucose and our glycogen. So this is really important to know this pathophysiology because a lot of times, and we see this all the time in people who come in who are like extremely hypothermic, maybe they're in cardiac arrest even, their glucose levels are way too low. You can't get someone back with CPR if you don't also address that problem.
Okay.
What are you laughing about?
No, I was gonna be like, I just remember if you move to a warm environment, your body will start to warm up.
That's basically what I was saying in a complicated way.
I know. Yeah, so that's the thing is we can treat the hypothermia and handle the body temperature and raise that body temperature, but now we have depleted glucose stores.
Right,
so we need to consider in the same way that we worry about depleted glucose did I say scores? What depleted glucose levels with like if someone has a seizure, right? Because the brain burns up a lot of that sugar. So just considerations we need to make. A lot of these body systems are working together, so we need to.
And this is like it's very simple, but again, this is one of the reasons this podcast we have for the back to basics. Like you forget that sometimes, right? Like if you can link metabolism, increased heat production. What do I need for metabolism? Glucose. Of course, I won't have glucose. Then you never forget that, I got to check a glucose on my hypothermic patients because you understand the why behind it, which I think is exciting.
And it's taking it. I would say it's more advanced than just a basic. I mean, you're taking it one step further. It's not. Right. We're not saying hey, you're freezing cold out here. Here's a popsicle. Your sugar is better now. Everything will be fine, right? We're saying after we've done the initial treatment, we've done the basics. Now we can think just one step further and go, okay, let's take care of the glucose.
Exactly. So, then if we continue to get even colder than that, shivering stops. So basically our decompensation, right? We can't shiver anymore. Then we start to core body temperature. We've been maintaining as best we can, trying to get back up there. Now it starts to go down rapidly. Yeah. And then we're going to start rapidly declining. You're even in mild forms of hypothermia, you might start seeing some altered mental status, which again makes sense. What does the brain use? Glucose, sugar. Right? Yeah. If we use up our glucose stores to shiver and do these things, we're going to have some, mental status change. We can start to go into arrhythmias and things like that.
It's exhaustion. I mean, you're exhausted because your energy stores are being burned.
Exactly. So there are actually 3 different, and I think it's, I think when we think about this continuum, that's the way we should be in medicine, considering different processes, right? Levels of altered mental status. We like to put things into categories of and we're about to do that with hypothermia.
Definitive ranges versus understanding.
Yeah, understanding that it's a continuum, right? And anybody can fall within the continuum. But we can, like I said in the textbook, break hypothermia up into 3 different ranges, basically. So do you want to go over those quick?
There's mild, moderate, and severe.
Right. Why don't you give the temperature
mild
range?
Is 95 to 93.
Yep.
I'm just reading the form right now. I don't know this off the top of my head. Moderate is less than 93. What? And I guess to 86.4, and then severe would be less than 86.4.
Yeah.
86.4. Holy cow, though. That's a huge range.
Yeah. So again,
the
mild
first
hypothermia.
One was 2 degrees. The third one is, I don't know. You do the math. 93 minus 86 is at least 15.
Exactly. Math's not a strong suit. But yeah, so you've got mild, moderate, and severe. And again, I don't think there's any need to necessarily memorize these. I think that for test taking purposes, maybe you can remember them. But again, think of it as a continuum. But you have mild, which is 95 to 93 degrees. So anything less than 95 degrees is mild. Once you get below 93 degrees, it's moderate. When you get below 86.4, it's severe. How they got 93 as a round number, 95, and then 86.4, I don't really know. But it probably some further research. If one of our listeners knows, please let us know. It probably has something to do with when your body stops certain mechanisms, right? When you stop shivering and things like that.
They're 86.3. No one has survived that condition.
Well, right. I think you start... I think, and I'd have to look this up, so don't quote me on this, but I think you stop shivering around the 93. So in the moderate range is when you start seeing
That makes sense.
The shivering.
Gotcha.
Severe hypothermia. I mean, these people are comatose.
Yeah.
They have, arrhythmias, maybe go into cardiac arrest, things like that.
Well, maybe let's go over that because I think instead of memorizing like a temperature range, like let's talk about symptomology.
Symptomatology and treatment based on the symptomatology.
Yeah,
I like it. So for mild, in the mild range, you're going to see kind of that, again, that increased metabolism, shivering, maybe a little bit of confusion and things like that. And that's where you're going to, that's kind of like the main thing you see in the mild range. So what are we going to do about it? So there's different rewarming techniques that we'll talk about, but the most important thing is what?
Rewarming them. Heat.
Well, but we talked about it earlier.
The environment.
Yes.
Take them out of the bad environment.
Exactly. Right.
I see it. It all comes full circle. That nonsense makes sense.
Exactly.
Now.
Right.
No, okay, I got you.
But yeah,
so
what is
take
the
them out of the
most
cold
important
environment.
thing to take them out?
Stop the bad stuff, right? It's just like what we put out the fire is the safest thing we do in the fire department, right? It's not necessarily just like treating the person who's actively burning, right?
Right. Yeah.
Put the fire out, right? So take them out of the environment, remove them from that environment. Remove anything that would be causing. So if they have wet clothes, we're going to remove those wet clothes because obviously water is it 25 times faster than air?
I think so, something like that.
That water sucks heat up. So we're going to remove wet clothing and things like that. And then we're going to work on what we would refer to as passive rewarming. And this would be like changing the heat of like turning on the heat in the ambulance.
Yeah. Yeah.
Right.
And actually that even might be considered like an external like rewarm. I think passive rewarming is basically like let the body do its thing now. Right. Like,
really? Oh, okay.
Yeah. But no, again, like getting them in a warm environment, like getting them out of wet clothes, putting on like a blanket, like that's.
I mean, don't not turn on the heat in the ambulance. You're like, you know what? No, this is only mild.
No, I agree. But
your body will take care of itself.
Same kind of thing. Like these general kind of passive ways to, we're not like actively engaging with the rewarming.
Gotcha.
In that thing. And the other thing, again, the important part to differentiate mild from moderate is that shivering component.
Mm-hmm.
So when we get to moderates, now when we get to temperatures like core body temperature below 93 degrees or 34 Celsius, now we need to start worrying about like shivering stopping, that increased tone, glucose and glycogen stores depleting. So when you see someone who's not shivering, their core body temperature is less than 93 or less than 34, if you're talking about Celsius, like we need to probably check a glucose. Another thing, is that they say now is the point where we have to start monitoring the ABCs. Not that we shouldn't always be monitoring ABCs,
right?
But like now is where we might see like respiratory issues,
like up to failure. Like we might need to take aggressive action.
Right? Exactly. Yeah, we may need to intubate a patient if they're too unresponsive and the GCS is too low, things like that. We actually want to prevent movement in this range, which is something kind of crazy that I read about. They're like, don't let the patient get up and walk around because the heart is very like sensitive at these low temperature range and they can literally go into VFib.
Oh, wow.
Yeah. Which is kind of crazy.
It's just conserving the energy so that we can run the basic systems.
Exactly. Yeah. You don't want them to exert energy doing anything because again, their glucose, their glycogen is depleted. They don't have the ability to increase metabolism. What that's going to do is potentially throw them into arrhythmias and things because the body can't handle it.
Cool.
So obviously we're going to monitor the EKG at that point
to see if they go into one.
Yeah. We're going to be reassessing their mental status as we try to rewarm them. And now we're going to be doing more passive and external rewarming.
So this is like heat packs in the armpits and the groin area, areas that are vascular and near the core. We can start warming that up. So crank the heat in the ambulance, heat packs in the groin area, like on the thighs, and then in the armpits. I'm trying to think, isn't there back of the neck is a popular one?
Yeah,
too.
I mean, sometimes like in the hospital, we have these like bear huggers, which is basically just like hot air over their whole body. But again, focusing in on the core, right? Like warming up their arms or their hands is that's not going to help, right? We're warming up their core. So, do you guys have those like those heat blanket things that?
No, we just do hot packs and we just have lots of normal blankets,
and
I mean, lots of places have heated. I mean,
do you do that?
The ER certainly has.
Yeah, we have a lot. I mean, like we'll do like share body heat. I'll do that a lot of time with patients.
What? Like, oh God, no.
But no. So now again, we
have like warming. We can do warm IV fluids.
I was going to say that too. Yeah. So this is probably the stage 2 where like we're putting an IV in, especially if we're worried about ABCs anyway.
That would be active rewarming, and it's a little bit more invasive than just external.
Right.
That's internal, obviously. So
So there's two different I guess we can talk about rewarming techniques. We have like passive and like active rewarming, and then like a passive technique can be like external rewarming. You know what I mean? So it's kind of
passive is just essentially changing the environment.
Outside
active would be changing them, right?
Yeah.
And then external would be would be defining
Yeah.
what type of active or passive we're doing.
So we'll actually sometimes in the ER, like I've done so if we had a patient who was in cardiac arrest, we got a pulse back, but their temperature was still super low, like 90 range, like very, very cold. Like
Mhm.
I think you came in like 88 or something like that.
Wow.
So we were doing CPR. So not only did we do like the hot packs and that kind of thing, we did IV fluids. We also put in an NG tube and a Foley and flushed warm fluids into the bladder and the stomach too, as a way to now we're very much actively
very active, very internal.
Right.
So-
And it's hard to snuggle someone naked like that when they have all those tubes.
Don't, in this day and age, why would you even make a joke like that? People are going to start shutting you down.
All right. Anyway, so then we moved to severe.
Next episode, she's going to be like, hey, I'm Jason Sykes with the Back to Basics podcast. Chris got canceled.
He got canceled. Yep. So the last thing is severe hypothermia, which again, now these people are comatose.
This is true. Like if you're thinking of this in terms of like shock, we have compensatory mechanisms. We have compensation. This is true decompensation now. So they're circling the drain.
This is failure.
Yeah.
This is This is complete decompensation. Like so they are usually comatose. A lot of times they're going to need CPR because their heart is going to stop or go into an arrhythmia. We really have to aggressively treat arrhythmias, which can be difficult because until the body's heated up, it's hard to get, like if I'm pushing medications into the periphery, are they getting to the heart? You know what I mean? Like we might want to put more like invasive lines in even like, if you're able to do like an EJ or like those types of things. And then again, a lot of passive, external and active, very active rewarming in this case. But that's one thing. So like from a CPR standpoint, and this is actually something I want to put out to the audience because I couldn't find a lot of data. Maybe I was just looking in the wrong place, but I know that I do this, and I know a lot of emergency physicians do this, and probably you guys do this in the field as well, is that we'll spend more time we'll do CPR for longer, knowing that if we can warm them up, we're going to have a better chance.
Mm-hmm.
So again, at some point, your metabolism is taxed so much that it completely slows down. There's a reason we cool patients after CPR, right? Because we want to keep their body temperature lower, not freezing, but like lower so that they can, more gradually like repair their body, right?
Mm-hmm.
So we'll do CPR for longer in cardiac arrest cases where there's hypothermia involved to see if we can warm them up and if that'll help CPR. Do you guys do that too? Like Yeah.
And like that, a lot of that stuff is like cold water drownings and stuff like that.
Mhm.
Like you're going to spend more time because of how especially like pediatric. And we talked a little bit about that when we talked about environmental emergencies. I think we did in our diving episode a little bit.
I think in the diving episode.
But like, the way that the brain shuts down, even like with cold, because it's shutting down gradually. It's not just like turning off oxygen to it. It's like you have a better chance of, it's not just a better chance of survival. You have a better chance of like quality of life afterwards.
Yeah. So that's one thing, and that's what I want to put to the audience, is that I had trouble finding the like data on that. Like, is that something that we do because we have had is there like, I don't know, have you read like data on like,
I thought
so. People who are at this temperature, like how long should be resuscitated them more than, I don't know. I've been like, I always know I do it longer.
Yeah.
And I try to,
I'm gonna look something
you're gonna look it up. All right. So basically what I'll do is, like I said, I will carry on a cardiac arrest longer while I try to rewarm someone because of this data that I think might exist out there that Jason will look up right now.
I'm like, here it is. It turns out if you take somebody out of a cold environment, they warm up.
I'm like, aha.
Facts.
So anyway, so that is the different types of hypothermia. I don't think it's as important to memorize the different types, but I think it's important to realize that there is a continuum and understand what the body is doing as things continue to decompensate. That increased metabolism, loss of glucose, shutting down of that type of thing is all super important to know. Memorizing the actual temperatures, I think you should know that like hypothermia is defined as less than 35 degrees Celsius or less than 95 degrees Fahrenheit. Whether you memorize the ranges for moderate and severe hypothermia, I don't think you necessarily need to do that. But just realize
we didn't mention you can warm and humidify oxygen. That's going to be the best way of oxygen delivery. Just so you know. Very
good point. Yeah. So when we talk about that active rewarming technique, another way we can do that is to do that warm humidified oxygen, which can absolutely go a long way as well. So obviously hypothermia is our like biggest, most I guess common topic to talk about within this realm of cold emergencies. But the other two I want to briefly cover and talk a little bit about their pathophysiology to be able to understand how to treat them and understand what's going on is frostbite and frost nip.
All right. I did find something though on hypothermia and cardiac arrest.
Let's hear it.
According to Google.
Nope.
No, I'm just kidding. No, rcemlearning.co.uk.
Okay.
So these would be people that only understand Celsius.
Okay.
They say primary hypothermic cardiac arrest usually requires severe hypothermia because hypothermia protects the vital organs, including the brain. Like you were talking about, things shut down, right? The prognosis of primary hypothermic arrest is better than non-hypothermic arrest, especially if the initial insult didn't involve asphyxia.
Okay.
So if you didn't die from lack of breathing and you died and it's cold out, you have a better prognosis.
Yeah. Which makes sense. I mean, it makes sense in terms of like why we cool patients after cardiac arrest as well. So, and actually the AHA I just saw also has recommendations on like a alternate ACLS for hypothermic patients where it has you checking the body temperature and really not terminating efforts until either you just can't get the body temperature up, which I've actually had happen, or you get it above, a certain number and still don't get anything.
Yeah.
So
gotcha.
Cool.
Anyway, frost nip and frostbite.
Frost nip and frostbite. So again, we're kind of talking about a continuum here. So the first thing is frost nip. So the first thing that happens to you when you're out in the cold. So this is what's going to happen to exposed parts of your skin, right?
You get hard.
Your fingers.
Wait,
what are you talking about?
The nips get hard. Oh, we're not.
No. No, so like your fingertips, like your earlobes, like exposed,
Yes.
that kind of thing. And it's frost nip is something that we probably, if you live in a cold environment, you've experienced every year. It's where your tips of your fingers get like red and numb and kind of tingly and burn a little bit. And that is a warning sign that like, don't keep doing this or you're going to get frostbite.
We're cutting off circulation at this point.
Yeah, exactly. What differentiates frost nip from frostbite is that there's no tissue damage. Okay, there's no tissue loss or tissue damage. So frost nip, basically you move into a warm environment. They say not to like rub your fingers together and stuff though, because as your sensation gets diminished, you can actually cause trauma if you're not too careful. So
you don't know you're hurting yourself.
Yeah, exactly. Yeah. So move into a warm environment, and frost nip is 100% reversible, right?
Yeah.
The blood flow continues, it goes on.
It's basically the difference between ischemia and infarct. We're just not talking about the cardiac muscle. We're talking about
even in frost nip though, there's not really any ischemia happening quite yet. It's more of just like that, like
well, like the neuropathy of it, like getting the tingling and the sensation
was just reversible.
Yeah,
exactly. I see what you're saying.
Yeah.
Frostbite is actual freezing of the tissues. So frostbite, I actually like to think of in terms, it's like a burn. It's just the opposite temperature, right? I mean, there's like, first, second, third degree frostbite, where first the tissue gets like, pale, yellow looking, loss in sensation, pain, burning, stinging, tingling. The tissue starts to then get hard. If it, you continue to stay cold, it starts to get more, hard. And then eventually turns cyanotic and harder, and you lose.
It dies basically,
right? So with frostbite, essentially to understand the pathophysiology behind that freezing of tissues and what happens is basically what happens is that you form ice crystals in the extravascular space. So in the tissue, there's like ice forms.
Your blood is freezing.
It literally freezes. Well, no, the extravascular space.
Oh, I'm sorry.
Yeah. So outside the blood vessels starts to freeze. Well, when that happens, it causes a fluid shift to occur. So basically, electrolytes move out of the cells because there's more crystal ice water formation in the extravascular space. So they move out of the cells, which causes cell damage. So you end up getting this like micro and macro vascular changes as well. Like you almost like get these like little like, you get damage to the vessel membranes, you get damage to the cells themselves, you start spilling potassium and stuff out into the tissue, just like you do in any kind of,
and like in a burn, when you're you have fluid shifting in a burn.
Right, exactly. Yeah. So in like first degree frostbite, you get that. If you rewarm, then what happens is you end up getting swelling, which makes sense, right? You increase blood flow, you get swelling, and you form blisters because all that fluid is extravascular now, and you get blisters and that sort of thing. As you move into like second degree, third degree frostbite, now you're talking about that freezing. Like now you're talking about even getting down to like the bone where like the tissue's frozen. So now it almost becomes necrotic, right? There, you can't, you try to rewarm it and blood flow can't get to the area because it's been completely damaged.
And that's where we're talking like amputation and stuff like that.
Right. Yeah, exactly. And just like burns, frostbite, you have to be very careful of like circumferential frostbite. Like now, obviously like frostbite is frostbite. So, but like, if you just the pads of your fingers are frostbit, you actually potentially have a better outcome than if like your entire finger is frostbit because it's that same kind of
Anything downstream, you're cutting off with a band. It's like a tourniquet.
It's like a tourniquet, right? Exactly. That tissue gets hard and necrotic. Well, then it constricts, and now you can have worsening ischemia and that sort of thing. So treatment for frostbite then basically is similar to what we talked about with hypothermia. One is remove the patient from the environment, and then start doing some like more active rewarming would be soaking their like finger. I use the fingers as an example, but soaking it in like lukewarm water. Why not hot water?
It'd be super painful.
No, because they can't feel it. Actually, the opposite. So like as you get frostbite, your sensory nerves. So these patients can get severe trauma. Like if they put their hands in like scalding water, they wouldn't even know it necessarily.
Well, don't make it scalding.
Well, that's what I'm saying. So lukewarm water. So just be careful.
Why not warm water?
That's lukewarm.
Or
is
hot
warm.
water, but not hot burn your skin water.
But how do you know if it's hot burn your skin water?
Because I'm going to put my hand in it first.
Maybe you have frostbite. You don't know.
No, it's not.
I'm just saying. So, but again, just keeping that in mind. Be very careful with the temperature. What you also don't want to do is put like a heating pad on the hand, because that direct heat, again, like they can't feel if it starts burning, if it's too much. You know what I mean? So keep that in mind. You also have to be careful with soaking too. You don't want to soak too long, because then you're going to start to get like
pruny.
Make it pruny, but you're also going to get like desquamation of the tissue and stuff like that. You know what I mean? Which can lead to infection and stuff. So, again, active and passive rewarming in the same context there. And then more advanced treatments, obviously, like you talked about, if it's severe, they really have to end up going to burn centers. They need debridement, they need amputation potentially, and things like that. And just like burns, it can be hard to tell what level it is. Even more so with frostbite. You don't know how deep that freezing happened. So like it might look like it's first degree now, but in 3 days, all of a sudden the tissue's turning black. So you just have to be really, really careful with those things as well. So that's pretty much it from like a frostbite, frost nip. Like again, it's a continuum. But understanding that pathophysiology of the freezing of the tissue and the electrolyte shifts in the vascular space and the microvascular damage obviously makes sense why we will form blisters as we rewarm, why we need to be careful, like with a burn, about circumferential and things like that. Because you can get that like that, what is that, like that escarotomy, like or that eScar type of like constricting.
It starts band constricting anything downstream. So even if you didn't frostbite or burn, the tip of your finger, if it's higher up, cuts off the circulation, and then you get a bunch of neuropathy issues. So another thing too, just to add in there, so actually like moving water. So like basically like having them put their fingers in like agitated water, like
jets,
jacuzzi.
like jets, like they'll have these like jet baths they'll put them in. It just like helps again with the circulation side of things too. If you could do that, you probably can't do that in the back of an ambulance.
I mean, I could take a straw and I could just blow bubbles the whole time. I could figure it out.
Just agitate the water yourself.
I'm like, no, my brother told me this is what we do.
Yeah. Okay, that makes sense. So, but again, with frostbite, you're getting actual cellular injury. Frost nip, right? Reversible, non.
Frost nip is like you're cool. Frostbite would be like, what's cooler than being cool?
Ice cold.
All
right. On that note, we appreciate you guys tuning in again this week. Again, our sponsor today, CPR Enroll, class management software. If you're a CPR instructor in whether you're AHA, Red Cross, or American Safety and Health Institute, you need a robust class management system that's inexpensive. Check out CPRenroll.com. They've got a lot of new features coming out soon as well. If you want to listen to this for credit, check out GuardianCME.com. Get free, 100% free CAPC credits for listening to our podcast, as well as other podcasts and other content that we put on there. Excited to have that launched. Again, we appreciate you guys tuning in, and we will see you next time.
Stay sweet.
Hey guys, thanks so much for taking a listen. If you are studying for the National Registry exam, we're here to help. We have a National Registry prep program to help you pass that exam. Check us out at guardiantestprep.com. If you'd like continuing education credits for listening to our podcast or watching this on YouTube, follow us at guardiancme.com. 100% free CAPC credits. No matter what state or country you're in, we're here to help. So again, we thank you so much for listening. We hope you have a wonderful week.